Hello and welcome to another session on human pathology for nurses. In today, we're going to describe the pathogenesis of disease in selected organs, and the selected organs for us will be looking at the kidney and the liver. So for the liver, we'll be looking at liver cirrhosis, whereas the kidney will be looking at the kidney failure and glomerulonephritis together with the nephrotic syndrome. Number two, we'll be able to define and identify the different kinds of cysts, also describe the neoplasms, comparing the benign and malignant tumors, staging and grading. And then lastly, we'll be able to describe metabolic and pigmentation disorders. So welcome. I hope this topic will be so helpful for all of us. So let's start by looking at the causes of liver cirrhosis. Okay, so in liver cirrhosis, we are saying the liver is scarred, guys. So the normal hepatic cells have been replaced by this fibrotic tissue. So what could be the causes? Number one, we are saying the cause could be alcohol abuse, generally the toxins. So we know that alcohol metabolism and alcohol hepatitis normally happen in this case. So that the fibrosis normally leads to the scarring and disruption of the liver tissue. Also, we also have fatty accumulation leading to fatty liver disease. B, we have biliary obstruction, and biliary obstruction leads to obstruction of the bile ducts, preventing bile flow. So, this normally results in cholestasis, and this cholestasis, this is impaired bile flow. So, the liver cell normally damage and fibrosis normally sets in. Next, we have chronic viral hepatitis. So viral infection, that is hepatitis B, C, and D, and chronic inflammation normally leads to this liver cell injury. So this also almost results into inflammation, which is characterized by continuous immune response. Also, another impact on the liver is that it normally results in fibrosis, leading to scar tissue formation. D, we have drugs, that is drugs like methotrexate, guys. Mechanism of these drugs is in the liver, leading to toxic metabolites, okay? So methotrexate leads to hepatotoxicity that is normally characterized by liver cell injury. Also, we have chronic liver damage and fibrosis. Okay. Here we have the extra. This is what. This is extrahepatic obstruction of the venous flow. We call it the Bad-Chiari syndrome. So this normally leads to obstruction of the hepatic veins, and this impedes blood flow. So as a result, we have ischemic injury that is resulting from a reduced blood supply causing cell damage and chronic inflammation and fibrosis. So guys, the causes of liver cirrhosis can be summarized as A, B, C, D, where A is the alcohol abuse, B is the biliary obstruction, C we are talking of chronic hepatitis. D, we have drugs like methotrexate that we have mentioned in our case. Then lastly, we have extrahepatic obstruction of the venous flow, what is generally referred to as the Bad-Chiari syndrome. All right. So what happens in liver cirrhosis? We have inflammation and fibrosis. So, and this happens in response to the injury where the liver undergoes inflammation. So the immune system normally triggers the release of cytokines and growth factors. This leads to activation of hepatic stellate cells. So these cells do play a critical role in liver fibrosis. They transform into myofibroblasts, which now when you have the myofibroblasts, this one they normally produce collagen and other extracellular matrix components, leading to fibrosis. Also, the fibritic tissue normally replaces the normal tissue architecture. So the hepatic fibrosis normally appears in three situations. It could be as a result of an immune response, or as part of this process of wound healing, or could be in response to agents that normally induce primary fibrosis. So conversion of these normal liver cells into fibrotic tissue normally disrupts liver functions, and one of the major functions is detoxification. Normally, the liver detoxifies harmful substances from blood. So, in cirrhosis, you'll have impaired detoxification, and this can lead to accumulation of toxins in blood. When toxins do accumulate in blood, it could affect the brain functions, and sometimes it causes hepatic encephalopathy, where the patient presents with confusion. Next, we have the synthesis of proteins, also as a function of the liver. So the liver produces essential proteins, including albumin and clotting factors. So if you have reduced liver function, it will lead to decreased production of these proteins. And this one, when we don't have albumin, we'll have albuminemia and lack of these clotting factors, leading to coagulation disorders. Another function is metabolism, where the liver normally regulates glucose metabolism and lipid balance. So if somebody has cirrhosis, then it's going to lead to insulin resistance diabetes and possibly dyslipidemia. Another complication is the portal hypertension. In cirrhosis, we often lead to increased resistance to blood flow within the liver. This normally leads to increase in pressure in the portal vein. And when there is increase in pressure in the portal vein, we refer to it as portal hypertension. Remember, this pressure forces blood to seek alternative pathways, leading to formation of collateral vessels, such as these esophageal varices and hemorrhoids. Portal hypertension can also cause ascites in the abdomen, where this process is normally characterized by accumulation of fluid in the abdominal cavity and splenomegaly. Splenomegaly is just enlarged spleen. So the liver, guys, liver. Somebody with liver problem could have loss of appetite, could have the icterus. This is the jaundice. Could vomit blood from these esophageal varices. Could also have edema. This is swelling in legs or abdomen, and could also have reversal of sleep pattern, daytime sleepiness. So this can only be arrived at or can easily be remembered by the acronym LIVER. Okay, so liver cash. Cash, we're having cirrhosis, cysts, this accumulation of fluid, splenomegaly, hepatic encephalopathy. So guys, to remember all the signs and symptoms of liver cirrhosis, we use the mnemonic cirrhosis, where we say C is somebody is going to present with constipation, somebody is going to have jaundice, somebody will have reversal of diurnal sleep pattern, somebody will have right upper quadrant pain due to this liver capsule stretch. Also, we'll have hepatomegaly, this enlarged liver. We'll have oliguria, this is decreased urine output, and the spider nevi. Spider nevi, these are vascular lesions on the skin. So, why will someone present with fatigue if you have liver disease? The damaged liver normally struggles to produce enough energy and metabolize nutrients. So this will lead to persistent tiredness and weakness. Thus, the patient will present with fatigue. And why should a patient with the liver cirrhosis present with jaundice? Remember, cirrhosis normally impairs liver's ability to process bilirubin, leading to build up of this bilirubin in bloodstream. So elevated bilirubin levels will cause yellowing of the skin and eyes, and thus the patient will present with jaundice. What about itching? Why should a patient with liver cirrhosis present with pruritus? You remember bile salts, which are not properly processed due to liver dysfunction, will accumulate in the skin, and this will cause intense itching. How about somebody with liver cirrhosis presenting with loss of appetite and weight loss? the impaired liver functions will affect the digestion and nutrient absorption. So this will lead to reduced appetite and unintentional weight loss. What about abdominal pain and discomfort? Well, cirrhosis can cause stretching of this liver outer covering. And when there is stretching of this outer covering, it leads to pain and discomfort in the upper right quadrant. It may also be due to inflammation or pressure within the liver. And why should someone present with nausea and vomiting? Liver cirrhosis can lead to digestive disturbances causing feelings of nausea and recurring vomiting. What about ascites? Well, cirrhosis will increase the pressure in the portal vein, and this normally causes fluid to leak into the abdominal cavity. And when this happens, it normally results into ascites and swelling. What about edema, especially swelling in the legs and ankles? Well, decreased protein production by the liver, especially the high albumin, leading to hypoalbuminemia, normally reduces the osmotic pressure in the blood vessels, and this leads to fluid retention and swelling in the extremities. What about the spider angiomas and palmar erythema? Well, you should know that altered blood flow in the liver causes changes in the circulatory system, leading to the appearance of these spider-like uh, blood vessels on the skin and reddening of the palms. Also, reduced oxygenation of blood due to the cirrhosis can also lead to clubbing, where fingertips and nails enlarge and take a curved appearance. Hepatic encephalopathy also may appear where the liver's inability to clear toxins from the blood can allow harmful substances to reach the brain, and this normally causes confusion, altered consciousness, and neurological symptoms. Also, somebody with cirrhosis is going to present with bruising and bleeding easily. Okay, so this cirrhosis normally impairs this liver production of clotting factors, and when this happens, it leads to easy bruising and bleeding. Also, the patients could present with dark urine and pale stools. Bilirubin build-up in the bloodstream can cause this dark-colored urine, or while the lack of bilirubin in stools makes them appear pale. Also, a patient with liver cirrhosis is likely to present with gynecomastia or testicular atrophy and amenorrhea. And remember that hormonal imbalances due to liver dysfunction can lead to these symptoms. So the liver normally metabolizes all these. So accumulation of these hormones could lead to uh, those abnormalities. Liver palpation. An enlarged and palpable liver below the rib cage indicates the liver structural changes due to cirrhosis. What are the complications of cirrhosis? So as cirrhosis progresses, complications could arise, and these include bleeding from the esophageal varices, ascites, hepatic encephalopathy, and an increased risk for liver cancer. It could also result into irreversible damage. So, the continuous cycle of liver cell injury and inflammation and fibrosis can result into irreversible damage to the liver tissue. So, as liver cirrhosis advances, the liver loses its ability to regenerate, okay? And this leads to decline in the overall liver function. So next we have chronic renal failure, guys. So chronic renal failure occurs when the functions of the kidneys have been reduced by chronic disease to the point that there is now retention of these nitrogenous waste products normally excreted in the urine. This reduction in the GFR can be detected by measuring the urine and creatinine in blood, and creatinine clearance from the blood and the 24 urine samples. Guys, a link will be popping up on how to conduct the creatinine clearance test. So the patient will present with an ammonia smelling breath. The patient will have loss of appetite, will have foamy urine, will also have difficult urinating or frequent urination. So there are 5 stages based on the GFR, where the stage 5 is somebody has 25% of the kidney function, and this is automatically kidney failure. Okay, correct, guys. So look at the causes now. For the causes, you're saying that you could have diabetes, where in diabetes you have damaged blood vessels and elevated blood sugar. You know that prolonged high blood sugars normally damage these small blood vessels in the kidneys, and this reduces their function over time. Hypertension, where this is characterized by increased blood pressure. So this increased blood pressure will normally damages these delicate blood vessels in the kidneys. This leads to kidney function, or reduces the kidney function. We also have the glomerulonephritis, and glomerulonephritis, this is normally characterized by glomerular damage and nephron inflammation. Inflammation in the glomeruli normally impairs the function and causes gradual kidney damage. Polycystic kidney disease, we have proliferations of cysts and kidney enlargement, and this could be genetic disorder causing fluid-filled cysts to form in the kidneys, and this gradually replaces healthy kidney tissues. Also infections, e.g. the pyelonephritis, so infections and persistent inflammation. We could also have obstruction of urinary tract, autoimmune diseases like lupus erythematosus. We also have the toxic exposure, e.g. the heavy metals, okay, heavy metals. And then lastly, we have the nephrotoxic drugs, e.g. the NSAIDs. The NSAIDs, they can damage renal tissues. And these drugs includes the NSAIDs, which can directly damage the tissues leading to CKD. So those are the causes of the kidney disease. So when you look at the pathophysiology, it starts by having the initiating insult, where CKD begins with an initial insult to the kidneys, which can be caused by conditions such as the hypertension, diabetes, glomerulonephritis, infection, autoimmune disease, or toxic exposure to substances harmful to the kidney. Remember, this we have already reviewed on the etiology. Then, initiating insult will lead to renal injury and inflammation, which will lead to compensatory mechanisms and glomerular hypertension and hyperfiltration. So, the initiating insult normally triggers an immune response within the kidneys. So, this inflammation can cause renal cells, particularly the glomeruli and the tubules. So, initially, the kidneys will activate compensatory mechanism to maintain filtration and excretion functions. So these mechanisms will include increased glomerular filtrate and hyperfiltration in the remaining nephrons to compensate for the damaged ones. But remember, compensatory hyperfiltration leads to increased pressure within the glomeruli. So while the mechanism temporarily helps maintain filtration, it also strains the glomeruli, making them more susceptible to damage. So from this one, we result into renal fibrosis and scarring, and then we have nephron loss and reduced function, decline of glomerular filtration rate, and uremic and clinical symptoms. And this, the end will be the end stage renal disease, ESRRD. Okay, great. So from there we have the uremia, and uremia is a condition resulting from build-up of these waste products in the bloodstream due to impaired kidney function, and it has complex pathogenesis. We could have toxic effects of the retained products, leading to the increased level of normal products, loss of kidney specifics, fluid shifts and electrolyte imbalance. We also have the subtotal, the alterations in kidney functions, and that can result into those uremias. So another key concept in this one is the mineral and bone. So we have several disorders of the phosphate, calcium, and bone metabolism are observed in the chronic renal failure. So the key factors in pathogenesis of these disorders will include diminished absorption of calcium from the GIT, So in chronic kidney disease, there is diminished absorption of calcium from the GIT, predisposing our patient to bone problems. Or we could also have overproduction of the parathyroid enzymes, okay, parathyroid enzyme. Or we could have disordered vitamin D metabolism, and lastly, chronic metabolic acidosis. So all these factors contribute to enhanced resorption. Remember, a link will be popping up on the different types of bone cells with their functions. But in this case, we have the osteoclast. So all these factors will contribute to enhance bone resorption, okay? Bone resorption. So bones are broken down, okay? So we have hypophosphatemia and hypermagnesia can occur through overuse of phosphate binders and magnesium containing antacids. Although hyperphosphatemia is more common, hyperphosphatemia contributes to the development of hypocalcemia and thus serves as an additional trigger for secondary hyperparathyroidism, elevating blood PTH levels, parathyroid hormone. So, the elevated parathyroid hormone further depletes calcium and contributes to osteomalacia for chronic failure. Okay. Also, the patient could present with these cardiovascular and pulmonary abnormalities, hematological abnormalities because of this reduced production of erythropoietin, guys. Could also have neuromuscular abnormalities. Some of the patients do present with asterixis. Asterixis is manifested by involuntary flapping motions seen when the arms are extended and arms held back. So patient will start having those involuntary flappings. It is due to altered nerve function and in metabolic encephalopathy from a wide variety of causes, including renal failure. Also, the patient could have speech dyspraxia. This is inability to repeat words. Also, myoclonus, dementia, and seizures. Patient with also chronic kidney failure may also have gastrointestinal abnormalities. So GI non-specific findings in uremic patients could include things like anorexia, hiccups, nausea, vomiting, and diverticulosis. Patient could also present with endocrine and metabolic abnormalities. Remember, women with uremia have low estrogen, which perhaps explains the high incidence of amenorrhea and observation that they rarely are able to carry out pregnancy to term. It is interesting to know that chronic renal failure normally eliminates the kidney as a site of insulin degradation. So therefore, you may find that it has increased the half-life of insulin. So this typically has a stabilizing effect on diabetic patients whose blood glucose was previously difficult to control. You find it's being controlled because of the increased half-life of insulin as a result of eradicating the insulin degradation site. All right. We could also have dermatological abnormalities where patients normally have the uremic frost, or also the patients could also be having the glomerulonephritis. Remember, these are disorders resulting in glomerular disease, whether manifestation of systemic injury or others fall into 5 categories. We could have acute glomerulonephritis, rapid progressive glomerulonephritis. So here in acute, there is an abrupt onset of hematuria and proteinuria with reduced GFR and renal salt. Whereas rapid progressive glomerulonephritis, with this recovery from this acute worsening kidney results into irreversible complete renal failure over weeks to months of the same case. We could also have chronic glomerulonephritis. Then number 4, we have nephrotic syndrome. Nephrotic syndrome, remember, it is normally manifested by marked proteinuria, particularly albuminuria, defined as 24-hour urine protein excretion of greater than 3.5 grams. The patient will have hypoalbuminemia, edema, hyperlipidemia, and fat bodies in the urine. We could also be having asymptomatic urine abnormalities. So the etiologies for glomerulonephritis normally occurs typically in setting for infectious diseases. Classically pharyngeal or cutaneous infections, okay? Okay, guys. So such patients, you remember, they are supposed to be put on droplet precaution. Guys, a link will be popping up on the different types of isolation precaution. Remember, the most common cause of asymptomatic urinary abnormalities is the group immunoglobulin A nephropathy. Okay, correct, guys. So we have different forms of glomerulonephritis and nephrotic syndrome, probably representing the differences in nature, extent, and specific cause of immune-mediated renal damage. So a number of cytokines are normally synthesized by mesangial cells, inciting an inflammatory reaction in some forms of glomerular disease. So although this classic association between natural history and defining fluorescence and electron microscope observation have been made, it is not known exactly how various forms of immune-mediated renal damage do occur. So each category is therefore described separately with its associated findings. So we could have acute glomerulonephritis, rapidly progressive glomerulonephritis, chronic glomerulonephritis, okay, and then those will be the different forms of this chronic failure. So guys, in our first objective, we were able to describe the pathogenesis of the cyst in selected organs, where we're looking at the kidney, at the liver, and we saw the liver cirrhosis. And we will also be able to highlight the kidney. And the kidney, we are looking at chronic renal failure and glomerulonephritis and acute nephrotic syndrome. Okay. So the next thing, guys, we're going to define the different types of cysts. Okay. Yes. So of course, symptoms of the cyst, the patient will present with pain or discomfort because of the encroachment of different spaces, swelling or lump, skin changes, and pressure or fullness. So a cyst is an abnormal closed sac-like tissue containing fluid, gas, or semi-solid material. Cysts are common and can occur anywhere in the body in people with any age. So they vary in size and may be detected only by a microscope, or they can grow so large that they displace normal organs and tissues. Remember, the outer wall of a cyst is called a capsule. So we have different causes of these cysts, where number one, you have wear and tear or simple obstruction or to flow of the fluid. So cysts can form due to wear and tear in joints or obstructions in ducts, tubes, leading to development of these cystic structures. Infection can cause cysts as the body tries to isolate and contain the infectious agent, forming a cystic structure around the invader. Both benign and malignant tumors can form cysts, either due to the tumor's internal necrosis or accumulation of fluid. Also, we also have chronic inflammation, genetic conditions, and defects during embryogenesis. So anomalies during embryonic development can disrupt tissue growth, leading to the formation of cystic structures. Okay? All right, guys. Okay, so from there, guys, we can now go to the next part of it, and here we'll be looking at the different types, at least different types. Our ovarian cysts, these are found in the ovaries, the renal, the kidneys, the pancreatic cyst in the pancreas. We have the dermoid cysts. These are found on the skin, especially on the neck, face, and upper chest. We have the ganglion cysts. Ganglion cysts, these are found in the joints or tendons, often in the hands or wrists. Okay. Bartholin cysts, these are found in the Bartholin glands located near the vaginal opening. Also the breast cysts, these are found in the breast tissue. What about the pilonidal cysts? These are found at the base of the spine, okay, near the tail. Chalazion cysts, these are found in the eyelids, particularly in the Meibomonian glands, okay. All right. We have also the thyroglossal ducts found in the neck along the thyroglossal ducts. Okay. Branchial cleft cysts, these are found in the neck. Also, we have the mucus cysts or mucoid cysts. These are joints. Sebaceous cysts, these are found in the skin, anywhere on the body arising from blocked sebaceous glands. We have the Becker cysts found at the back of the knee, arising from excessive joint fluid, synovial fluid. We have the colloidal cysts. These are found in the brain within the third ventricle, although rarely. Okay, and they're usually benign. We have the ovarian follicle cysts. These are found in the ovaries during menstrual cycle. Then lastly, we have the Talov cysts. These are found in the spinal nerves, especially in the sacral region of the spine. Okay, guys. Correct. So most cysts, we should know that they are benign, but some may produce symptoms due to their size and or their locations. So rarely are cysts associated with malignant tumors or serious infections. All right, guys. So the next objective, guys, you're supposed to cover is to describe neoplasms. Look at B and M staging and grading. Okay. Remember, a neoplasm is an abnormal growth of a tissue that can be either benign or malignant. So, neoplasm, they literally means new growth. Okay, it is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissue. So it persists in the same excessive manner after the cessation of the stimuli which has evoked the change. So neoplasm is often referred to as the tumor, and the study of tumors is what we refer to as oncology. So neoplastic cells are said to be altered from the normal cell behavior because they continue to replicate irrespective of the regulatory mechanisms that control normal cell growth. Okay? So neoplasms, therefore, they enjoy a certain degree of autonomy and more or less steadily increase in size regardless of their local environment, the nutritional status of the host. All neoplasms depend on the host for their nutrition and blood supply. Some neoplasms will require endocrine support, and such dependency sometimes can be exploited to the advantage of the neoplasms. In oncology, the division of neoplasms into benign and malignant is very important. This categorization is based on the judgment of the neoplasm's potential clinical behavior for that matter. So all tumors, whether benign or malignant, will have two components. One will be the parenchyma, which is normally made up of these transformed or these neoplastic cells, and the supportive host-derived neoplastic stroma made up of the connective tissue, blood vessels, and host-derived inflammatory cells. So the parenchyma of the neoplasm largely determines its biological behavior, and it is the component from which the tumor normally derives its name. While the stroma is crucial for the growth of the neoplasm, since it carries blood supply, provides support for the growth of those parenchyma cells. So guys, starting with the Benign tumors. A tumor is said to be benign when its features show that it will remain localized and it is amenable to local surgical removal. The patient generally survives. However, benign tumors can produce more than localized lumps, and sometimes they are responsible for serious diseases. So generally, benign tumors are designated by attaching the suffix "oma" to the cell type from which the tumor arises. So a benign tumor arising from the fibrous tissue is referred to as, can someone give us a guess? Fibroma. Very good. Whereas a benign cartilaginous tumor will be referred to as a chondroma. So the nomenclature of these benign epithelial tumors is more complex. They are classified sometimes on the basis of their microscopic pattern and occasionally on the basis of their microscopic pattern. So others are grouped on their cells of origin. For instance, the term adenoma is applied to benign epithelial cells reproducing gland patterns and to neoplasm derived from glands, but not necessarily exhibiting gland patterns. Like the papillomas. Papillomas, these are benign epithelial neoplasms growing on any surface that produces microscopic or macroscopic finger-like fronts. So, while on the other hand, the cystadenomas, these are hollow cystic masses. Typically, they are seen in the ovary. Lastly, we have a polyp. The polyp is a mass that projects above a mucosal surface, such as the gut, to form a macroscopic, visible by naked eyes. Okay? So although this term is commonly used for benign tumors, some malignant tumors also appear as polyps. All right? So what about malignant tumors? Malignant tumors are collectively referred to as cancers. Okay? Malignant implies that the lesion can invade, destroy adjacent structures, and spread to distant sites, that is metastasize, to cause death. Okay? Remember, when they are metastatizing, they normally metastatize to vital organs like the brain, the heart, the lungs, the kidneys, the liver, the bones. Okay? Remember, not all cancers pursue so deadly a course. Some are less aggressive and can be treated successfully, but the designation malignant constitutes a red flag. Okay. All right, guys. Malignant neoplasms arising in mesenchymal tissue or its derivatives will be referred to as the sarcomas. So, a cancer of fibrous tissue origin is the fibrosarcoma. And a malignant neoplasm is composed of chondrocytes will be chondrosarcoma. So sarcomas are designated by their histogenesis, that is the cell type from which they are composed. Malignant neoplasm of epithelial cells or origin are referred to as the carcinomas. It must be remembered, guys, that epithelia of body are derived from all the three germ gears: ectoderm, ectoderm, and mesoderm. A malignant neoplasms arising from the renal tubule epithelium, that's the mesoderm, is a carcinoma, as are the cancers arising from the skin, that's the ectoderm, and the lining of the epithelium, the endoderm. It is evident that mesoderm may give rise to carcinomas and sarcomas. So carcinomas, they grow in particular pattern and are referred to as adenocarcinomas, while those that produce squamous cells are referred to as squamous cell carcinoma. Okay? Correct. So sometimes the tissue or the organ of origin can be identified as the designation of the renal cell adenocarcinoma or cholangiocarcinoma, which implies an origin to the bile duct. Sometimes the tumor shows little or no differentiation and must be called poorly differentiated or undifferentiated carcinomas. For instance, a tumor cells may undergo divergent differentiation, creating so-called mixed tumors. The best example for a mixed tumor is the salivary gland. Okay, so these tumors have obvious epithelial components dispersed through a fibromaxoid stroma, sometimes harboring islands of the cartilage or the bone. All these diverse elements are thought to derive from epithelial cells, the myoepithelial cells, or both the salivary glands, and the preferred designation of this neoplasm is the pleomorphic adenocarcinoma. So the fibroadenoma of the female breast is also another good example for a mixed tumor. So this benign tumor contains a mixture of proliferated ductal elements embedded in a loose fibrous tissue, the fibrome. The multifaceted mixed tumors should not be confused with the teratomas. Teratomas, remember, they contain recognizable mature or immature cells or tissues representative of more than one germ cell layer, and sometimes all the three. Teratomas originate from totipotential stem cells, such as those normally present in the ovary and testis, and sometimes abnormally present in sequestered midline embryonic rests. Such cells have the capacity to differentiate into any of the cell types found in the adult body. So, not surprising, this may give rise to neoplasms that mimic in a helter-skelter fashion bits of bone, epithelium, muscle, fat, nerve, and other tissues. So some glaring inconsistencies may be noted. So, for example, the terms lymphoma, mesothelioma, melanoma, seminoma are used for malignant neoplasms. So someone may confuse them with benign. Okay? So these inappropriate usages are firmly entrenched in the medical terminology. Although the terminology of neoplasm is regrettably not simple, it is important because it is the language by which nature and significance of tumors are categorized. So we can look at it in terms of the degree of differentiation, the rate of growth, local invasiveness, and distant spread. So for this matter, all right, guys. So in terms of degrees of differentiation, you find that benign tumors, they normally resemble the tissue of origin and are well differentiated. It means they look like the normal cells. But for malignant cells or tumors, they are poorly or completely undifferentiated, unplastic. They are different from the cells or from the original cells. In terms of rate of growth, you find benign is slow growing, while malignant generally grows faster. Local invasive, you find that benign tumors are well circumscribed and have a capsule, whereas malignant, they are poorly circumscribed and they invade the surrounding normal tissue. Lastly, in terms of distant, saying that benign, they normally remain localized in the site of origin, whereas the malignant, they locally invasive and they may metastasize to distant sites. So we have carcinogenic agents. So three classes of carcinogenic agents can be identified. We could have chemicals or radiant energy or microbial agents for that particular matter. Okay? So let's look at grading of tumors. remember that in grading, it describes how normal or abnormal a cancer cells looks like when you look at a microscope. So under a microscope, you are able to note the shape of the cells, the size of the cells, the type, the color, and the arrangement of these cells. So the more normal the cells look, the less aggressive the cancer is, and the more slowly it grows and spreads. And equally, or when you compare it now to abnormal cells, we are saying that the more abnormal the cells look, the more aggressive the cancer will become, and the faster they are likely to grow and spread. So we have this grading and staging normally help determine the prognosis and the treatment of these malignant tumors. So grading is macroscopic and microscopic degree of differentiation. Okay, so gross features like exophytic or fungating appearance are indicative of less malignant growth as compared to diffusely infiltrating tumors. It's based on two distinguishable features, that is the degree of anaplasia plus the rate of growth. Okay, and this one normally divides this grading of cancers into 4 stages. Grade 1, we have well differentiated cells where they are only less than 25% that are anaplastic cells. So here you find cells look very similar to the normal one. The tumor is slow growing and less aggressive, and generally grade 1 tumors have a better prognosis and are easier to treat. Grade 2, these are moderately differentiated and it's made up of around 25 to 50% anaplastic cells. So cells are somewhat abnormal, but still they resemble the tissue of origin. You find the tumor is moderately aggressive. The prognosis and treatment options depend on the specific type of cancer. Next, we have grade 3, and this one they are poorly differentiated cells. They are made up of around 50 to 75% anaplastic cells. So cells appear highly abnormal and do not resemble the tissue of origin closely. Tumor fast growing and more aggressive. So you find that generally grade 3 tumors are associated with poor prognosis and may require more aggressive treatment. What about grade 4? This is made up of undifferentiated or anaplastic cells. We have more than 75% of the cells are anaplastic. Okay? So cells appear highly abnormal and bear little or no resemblance to the cells of origin. These types of cells have very aggressive, highly aggressive, and rapidly growing. Okay, so grade 4 tumors are associated with poor prognosis and are often challenging to treat. Remember, grading in most cases is subjective, and the differentiation of the degree of differentiation may vary from one section of a tumor to another. Pathologists have therefore commonly grading these tumors in descriptive terms such as well differentiated, undifferentiated, keratizing, and non-keratinizing. Okay, so differentiated, these are cells in well differentiated tumors. They resemble normal cells of the tissues and they originate from. They maintain specialized structures and functions. Find that these cells are in undifferentiated tumors. They lack features for normal cells. They appear highly abnormal and do not resemble cells of the origin. They are more often aggressive. What about keratinizing? Keratinizing refers to the presence of keratin. This is a fibrous protein. So keratinizing tumors contain cells that produce keratin. And this term is often used in the context of epithelial cells such as the squamous cell carcinoma. So non-keratinizing cells, this one indicates the absence or minimal presence of keratin. So this type of cells do not produce significant keratin, and this term is also commonly used in describing squamous cell carcinomas and can indicate more aggressive form of disease. So what about the grading terminology for specific tumors? So we could have well-differentiated adenocarcinoma, poorly differentiated and mucinous, or these non-mucinous. Okay. What about the histology grading? If we could have low-grade tumors, intermediate tumors. Okay, the behavior of these tumors falls between low-grade and high-grade. For high-grade tumors, these tumors are poorly differentiated and or undifferentiated. So these tumors tend to grow and tend to be more aggressive and grow rapidly. Okay. Okay, what about staging, guys? So staging is the extent of the spread of a tumor within the body, and it can be assessed in three ways: clinical examination, investigations, and pathological examination of tissues. Staging of the cancer does not change, it's only the changes are incorporated in the original staging. So we have two major current staging systems, although we have more than this. So we have the TNM staging, where T stands for the primary tumor, N stands for nodal involvement, and M stands for metastasis, distant metastasis. So it ranges from T0, N0, M0 to T4, N3, M2. So for each of these components, the numbers are added to indicate the extent of involvement. So T1 to T4, this one will range from the in situ lesions to the largest and more extensive primary tumor. Here it's ranging from no nodal involvement, N0, to widespread lymph node involvement, N3. We also have no metastasis to disseminated hematogenous metastasis, so M0 to M2. Another staging criteria is the AJC staging, American Joint Committee. So this American Joint Committee staging takes into account all the components of the TNM staging and divides all cancer from stage 0 to stage 4. Both staging can be applied to most malignant tumors. So stage 0, here this is cancer in situ. Early stage, this is localized to the original tissue. Stage 1, this is localized tissue that has not spread to nearby lymph nodes or other organs. Stage 2, we have localized cancer with larger size or greater extent of invasion. Stage 3, we have cancer that has spread to nearby tissues, lymph nodes, or structures. Stage 4, we have advanced cancer that is spread to the distant organs or distant lymph nodes. So we also have the laboratory stage diagnosis, where we have pathological diagnosis of tumors. So the tumors can be done clinically, radiologically, biochemically, or through microscopic examination. And depending on this procedure used to get a sample to be examined, the whole lesion or larger or a small sample of the cells may be studied. So we could use an X-ray to detect tumors in the bones and certain tissues, or the CT scan. CT scan, this provides detailed cross-sectional images of the body to identify the tumors and their location. Could also do the MRI, magnetic resonance imaging. This uses powerful magnets and radio waves to create detailed images of soft tissues, helping in tumor detection. Ultrasound uses sound waves to create images of internal organs and is commonly used for detecting tumors in organs like the liver, ovaries, and the prostate. We have PET, this is positron emission tomography. It combines the PET and CT scan to show the both structure and function of structures, helping to identify active tumors. We also have types of biopsies. We could do needle biopsy, surgical biopsy, or endoscopy, upper endoscopy, colonoscopy, and bronchoscopy for that matter. We could also use the blood test, where we identify the tumor markers. This one will measure the specific substances produced by tumors. We have elevated levels might indicate the presence of certain cancers, although these markers are not definite for cancer diagnosis and are used to monitor the treatment response. Could also do the CBC, could also do the genetics tests like the genetic screening and next generation sequencing. Okay. Okay, next we could have the genetic tests where we do the genetic screening, next generation sequencing. Okay, also nuclear medication test, histopathologies, molecular profiling, and so on. So we have different types of biopsies and their role. Okay, so could have just get this one. So type number one, we have the punch biopsy, where this one we remove small cylindrical tissue, especially for the skin. Incisional biopsy, where a portion of abnormal tissue is removed. Large lesions are complete removal isn't practical. Excisional biopsy, where we have the entire abnormal tissues removed, especially if there is a small or easily accessible lesions. Then we could do the needle biopsy. This a thin needle withdraws the cells, or the core needle. This needle removes a small core. It's very important for the breast, prostate, and other solid biopsies. Could also do the endoscopic biopsy, bone marrow biopsy, sentinel lymph node. This contains containing like metastases in biopsy. Okay, staging cancers to assess extent of lymph node involvement. We also have curate and biopsy, where tissue is scraped from the surface of a lesion using a curate. And lastly, we have the laparoscopic. Okay, laparoscopic biopsy, where we have minimal invasive surgeries performed using laparoscope to obtain tissue samples for internal organs. So we have different markers for different types of cancers. Okay, like what is the tumor marker for breast cancer? We have the CA 15-3, CA 27, 29. Okay. For prostate cancer, we have the prostate-specific PCA antigen, where levels needs to be less than 4. Of course, these levels may vary with age. Also, we need to know that. Or for colon, we have the carcinoembryonic antigen, the CEA. It should be less than 5. Also have the liver cancer. We could measure the alpha protein, and it should be less than 7. Also, for the testicular cancer, alpha protein, we have it here. Okay, so we have these different tumor markers for different types of cancers. Okay, guys, so the last objective is to describe the metabolic and pigmentation disorders. Okay, so difference between pigmentation and metabolic disorders. We have could have the features, metabolic pigmentation disorders, and then metabolic disorders. Okay, so we have the definition is saying that disorders affecting the color of the skin, hair, and eyes. Whereas the metabolic involves disorders related to the body metabolism, including energy production and storage. Also, the affected areas, you find in pigmentation, you have mainly the skin, the hair, and the eyes, whereas metabolic affects various systems and organs, including endocrine system, such as the diabetes, thyroid disorders. For the causes, pigmentation disorders are caused by genetic factors, autoimmune reactions, hormonal imbalances, and sun exposure. It's almost the same for the metabolic. Okay, so where we have genetic factors, cutting. We also have the lifestyle choices here and hormonal imbalances, just like the pigmentation. So the primary symptoms for pigmentation, we have skin discoloration, changes in skin color, presence of patches or spots. Whereas for metabolic, we could have abnormal glucose metabolism, obesity, changes in body weight, fatigue, and excessive thirst and hunger. For diagnosis, pigmentation disorders will be diagnosed through visual examination, sometimes aided by skin biopsy for detailed analysis. Whereas metabolic disorders will be diagnosed through metabolic tests, imaging, okay, and imaging tests. Common examples for pigmentation, you have vitiligo, we also have albinism, we have melasma, we have freckles, we have hemochromatosis, while for the metabolic disorders, we could have DM, diabetes, obesity, hyperthyroidism, hyperlipidemia, and polycystic ovary syndrome. So the complications will include emotional distress, increased sensitivity to light, vision problems. Whereas for the metabolic, we have cardiovascular diseases. Lastly, we have treatment options where this one is normally characterized by topical treatments, the creams, the ointments, light therapy, cosmetic, camouflage. Whereas the metabolic, we could have lifestyle modification on their diet and exercise. Then we also have the medication like insulin or anti-diabetic drugs or surgery in certain cases. So, examples could include for pigmentation, we have the vitiligo, albinism, melasma, freckles, lentigs, the negraccans. We have the hemochromatosis and the porphyria and also Addison's disease. Okay, Addison's disease. For the for the metabolic disorders, we have the diabetes, obesity, hyperthyroidism, hypothyroidism, hyperlipidemia, and phenylketonuria. Also, galactosemia, Williams disease, lactose intolerance, gout, celiac disease, the POS also examples in that case. And it could be caused by intracellular accumulation of lipids, which leads to normal, which is classified under the normal cell constituent and abnormal substance. Okay, so in intracellular accumulation of lipids could lead to fatty change, and this one fatty change. So we now have fat degeneration and fat infiltration about the same. So lipids normally leave the liver as lipoprotein. So fatty liver can develop if we have excessive entry of lipids into the liver, could have enhanced fatty acid synthesis by the hepatocytes, and could also have reduced oxidation of fatty acids by the mitochondria for that case. So those are some of the differences, different types of metabolic and also the pigmentation disorders for that particular matter. I hope that was helpful for that section. Lastly, we have the four principal causes of hypercalcemia, and hypercalcemia, increase in calcium, could be due to increased secretion of the PTH hormone. Okay, and because this one normally increases the osteoclastic activity. Okay, leading to destruction of bones and simultaneous increase in calcium in the blood. Could also have destruction of bones secondary to primary tumors. Primary tumors could also lead to destruction of bones, like the Paget's disease and breast cancer. Also, we have vitamin D related disorders, including vitamin D intoxication or sarcoidosis, or idiopathic hypercalcemia of infancy, the one that we normally refer to as Williams syndrome. This one is characterized by abnormal sensitivity to vitamin D that normally affects the metabolism of vitamin D. Lastly, we have renal failure, which normally causes retention of phosphate, leading to secondary hyperthyroidism. So guys, this is a plan where I should be able at least to see the normal metabolism of calcium. So normal blood calcium. So increasing blood calcium will lead to PTH suppressed. Okay, so this one we have reduced bone resorption. When this one is suppressed, urine secretion will increase, and also the production of D will decrease. Okay, so if you have decreasing blood calcium, then PTH will be stimulated. If it's stimulated, then bone resorption will happen. Okay, breakdown of bones to increase more calcium. Urinary secretion will decrease so that more calcium remains behind, and also vitamin D will increase to help aid in absorption of calcium. So guys, those are some of the review questions that you need to attempt for this topic. You need to be able at least to describe the pathogenesis of liver cirrhosis, describe the pathogenesis of chronic kidney failure. You state the various ways of diagnosing tumors. You also need to classify cancers from grade 1 to grade 4 and describe each stage. That was grading, and equally you stage from grade 0 or class 0 to class 4. And lastly, you state 4 causes of hypercalcemia. I hope guys the presentation has been informative and also helpful for your course. Thank you so much and take care. See you again.